Thank you so much, Jamie. And thank you to Nick and Amber Lynn as well, who are behind the scenes and who together are making this webinar possible. And thank you to our panelists for joining and sharing their work and experience with us today. It is so great to be here with you all. I'm going to get started actually with you, Leslie. Thank you for joining us. I'm grateful to have inherited this relationship between the ABIM Foundation and IHI. We entered into a partnership around this work and chose explicitly to focus on trustworthiness, being deserving of trust, instead of just trust, the belief in the trustworthiness of others. The thinking here is grounded in this belief that we can't seek trust without being trustworthy, but I'm hoping you can tell us a little bit more about this framing and why it was so important to IHI.
So first of all, thank you, Jess, and the whole ABIM Foundation team for inviting us into this conversation today. And I want to not take up too much space because I think that folks want to hear from the health systems. But I do want to thank you as well for engaging IHI and our partner health systems on this important topic and trusting us to be in partnership in this work. You outlined much of it already, Jess. I mean, our view on trustworthiness and trust is that it is the responsibility of each of us as leaders, as organizations, as human beings to behave in ways that are trustworthy. And really, that's all that's within each of our sphere of control. In family systems work, there's a saying, change me to change we. And this is the work. It's about me, me as a leader, each of us in our organizations behaving in a way that is trustworthy so that we can change the experience of we and build trust. So that was the opportunity for improvement that IHI saw the space where we could really bring improvement science to bear.
Yeah, and I don't think we need to make the case for that work here. I think the community on this line especially, they've been very much a part of that dialogue. But one thing that it's sometimes challenging to know, either as a patient or maybe if you're exploring working in an organization, is how do you know? What does a trustworthy organization actually look like or feel like?
Such a good question. And I would say that there are established measures of trust, which, as we just discussed, is an outcome. And we used one in our work together, and I'll actually put the link in the chat to an important seminar that ABIM Foundation and Academy Health had about measuring trust. So there's surveys that exist that organizations can use to understand their level of trustworthiness. But back to your question about what it looks like. I mean, what we're learning is that a health system that is trustworthy is more likely, for example, to have higher net promoter scores, both internally with workforce and externally with customers and with our communities. Lower workforce turnover, higher engagement of care with our communities. So when we ask about what does a trustworthy organization look like, it's one that is excelling on those measures that matter to each of us, to our communities, to our health systems. That's really how I think about it.
Great. Yeah. And we'll talk more about how to actually move those needles on things that maybe are more publicly available leading indicators of trustworthiness and trust. Part of your work was creating a theory of change in relationship with the pilot sites and with partners in the space. Can you tell us a little bit about the theory of change that guided the learning system around it?
Sure. And this may be clear to everybody, but I just want to say that a theory of change is just an articulation of what it takes to achieve an improvement. So it just, and we have right here what the theory of change is that we use to improve trust between a healthcare organization and the workforce, and the healthcare organization and the community that it served. So IHI started this work with your support, the support of the ABIM Foundation, by learning about what the drivers of mistrust were. And then based on our literature review, our desk research, input from many, many experts, we developed really this three-step approach to build and strengthen trust. And I want to acknowledge that it was inspired by the work of Dr. Michelle Morse and Dr. Brent Wispelite, who designed and tested a model called Healing Arc. To address systemic racism leading to inequitable patient outcomes at Brigham and Women's Hospital in Boston. And so we also centered this work on equity. And when we went and asked and learned about what the drivers of mistrust were, we centered that on the experience of communities of color. And so we said there's really these three primary drivers. There's acknowledging breaches of trust. So saying, yes, this has happened. We can maybe get into a conversation about whether and when that includes an apology, but I'll put that over to the side. But there's the acknowledgement that there's been a breach of trust. There's the work of redressing it and of fixing it, and what can we do to improve now? But it doesn't stop there. It's what do we need to do to build systems so that the mistrust doesn't happen again, and that we can have systems that reliably demonstrate and the organization and each of us showing up in a trustworthy way. I'll chat in a link to this in more detail. And I'm glad to dive into any of it, but that's a theory of change at a relatively high level that each of our health systems worked with us on testing.
Thank you so much, Leslie. And I'm glad you said we can bookmark the acknowledgement piece, because I think it's a challenging piece and one that we should dive into further. And we keep saying systems. We can say learning systems and building systems. And so what does that mean? And why was it important in the design of this work to build a learning system around the sites who got involved with us, and who were they?
So a learning system is a community of health systems and teams from health systems that intentionally come together to very explicitly, in this case, test the feasibility of putting those drivers into practice. So we had an amazing group of health systems. We had Parkland, Rise Up New York, Banner Health, Denver, M Health Fairview, Oak Street, and Indian Health Services, who were part of our learning community. You're going to hear from some of them today, and together. They really taught us about whether it was feasible to put those drivers into practice. And they tested, and I'll let the health systems talk about it, but they tested things like working with communities of people who were planning to give birth at the hospital. How do we work with that community? And how do we work with the workforce that is supporting that community? So we had teams that focused specifically on physician burnout, and how could we implement these drivers to address that, and also health systems that focused on improved joy in work. And I am saying health systems, but I do want to be clear that this was early stage work where we were learning about feasibility. And so we asked each of these health systems to identify a population in the community and in their clinical setting that we could test with. So it was a part of a health system, but the parts of each of those health systems came together to share data, to share learnings, to learn from each other, and to learn from expert faculty around that theory of change.
That's a perfect segue, and thank you for that explanation, Leslie. It's a great segue to Crystal Matthews and Surabhi Bhatt, who are here from Oak Street and Rise Up. And there was work to drill down from the leadership level that you engaged to be involved in this work, and then to the teams that you ended up leading in this work. And so I'm curious, from your perspective, why do you think it mattered to your leaders to get involved in this in the first place? And do you think that there was a problem that this solved for them? So maybe we'll start with Surabhi. Yeah.
Sure, happy to do this, and thank you again, Leslie, for frankly getting us involved in this work, and ABIMF for supporting and championing this from the beginning. I mean, truly, for Oak Street Health, we uncovered so many learnings, so we were so glad to be part of this. So for those of you that don't know, Oak Street Health, we are a national network of value-based primary care centers. and we serve over 200,000 folks across 25 states in medically underserved areas that are identified across the United States. And our mission was really founded to rebuild healthcare as it should be. So our core mission being anchored on that, I think, primed us perfectly to dig into and address key problems within the US healthcare system in the work that we do every day in delivering better care to our patients and impacting their health outcomes. And then this, I think, also translated into, how we started thinking about how do we support our frontline clinicians and care providers, many of whom, by the way, are BIPOC, and that come from the communities that have been disproportionately impacted by systemic issues, by marginalization and racism. And so to this end, we saw a really strong directive and commitment from our senior leadership and the executive team to make sure that Oak Street was open to exploring all of the different ways that we can continue to support our mission that is aligned for not just our patients, but then also our teammates, including ways that we can continue to enhance and improve. So that's sort of from an Oak Street perspective where we kind of started. But I know for a fact that Crystal has a lot to share there also.
Yes, thanks so much again for this opportunity. I will say Rise Up East New York is just our main initiative for Dreyfus Health Policy and Research Center. And I am fortunate enough to say that we're both in the community and we partner with One Brooklyn Health in this particular project, who served as the healthcare system. So we found that with One Brooklyn Health, we focus on the sickle cell population, those with sickle cell disease. And we found that many of them, they had town hall sessions and listening sessions in these forums just to hear the concerns, how things could be better for patients or those with sickle cell. And many spoke of the disconnect between the care they received on the outpatient side and that they received when they were inpatient. So it allowed us to be able to take a look at what can be done in the community, in addition to what goes on once they're admitted, if they had to be admitted. It was a good thing that leadership really wanted to be involved to know what they could have done better. So it made it a lot easier for us to partner together to see if we could work to that end. So in addition to working with that sickle cell population from One Brooklyn Health, we also had our New York housing development. There are specifically 11 in the East New York area. We focused on one that really wanted to improve their health. And this served as the community-based side of people who wanted to see that their health improved. I'm a resident myself of East New York, and as a nurse, I can see day to day things that weren't being addressed, things that residents just didn't know. So like, how do we bring care into the community? So this way they don't necessarily wait until they get to the hospital, where things are sometimes at that point so far gone. There are things that can be done in the community, resources that can be provided so they can be educated and not only educate themselves, but their families and others in the community as well.
That's so great. And it sounds like you both have some pretty forward-thinking leaders who saw a line of sight between either strategic priorities that they had or their overall mission, and they saw this work as an opportunity to act on that mission and improve outcomes, which is, it's not everyone that does that. And it can also be a challenge to identify, if you are going to pick a pilot site to start, which one? Do you pick a site that is maybe struggling and actually needs the support, or do you pick a spot that's a bright spot who has maybe some more bandwidth to take this on? And that's really always a tension. And it sounds like they struck gold by picking the two of you to help lead this work. And so I want to hear more about the work you did and what some of the outcomes were that you saw. But I'm actually going to start with your experience of being in a learning system, what it was like learning from the other sites, what you learned from, with, or about the other sites. And I know that the beginning, this is a two-parter, can often be really challenging. There's a lot of activation energy to hop into an effort like this. And so what was that like for you? And can you name some of those challenges? And either of you can go first. Yeah.
I'll quickly go first, but Crystal, please jump in. Is that, and I was reflecting on this after we had the prep call, Jess, and, I was thinking about this, is that while there were a variety of different healthcare organizations, so there were tertiary health centers, we had FQHCs, There's obviously a value-based primary care org like Oak Street that was part of this, that were participating. So there are all these different, if you can say, like flavors of health systems that were part of this. But the interesting thing, and Crystal, I feel like you would agree with me here, is that, as we kind of progressed in our work and as we had these, in-depth conversations, we realized that we all were sort of struggling with the same issues around trust building. So we discovered that like we all needed to do better at asking what matters to you. There was a greater need for like in their shoes perspective, more transparency regarding like the why on key decisions, like clear acknowledgements of past breakages of trust, like Leslie highlighted, and then for more robust responsibility structures. And then like finally, like the co-creation of an action plan, because it is often really easy for folks that have a perspective with high activation energy, like you said, Jess, to jump in and say, oh, we know how to solve this, right? But it takes a lot more intentionality to sort of jump in and say, let's actually methodologically study this, but then also like really talk to the people disproportionately impacted by this and co-create a plan to rebuild and restore the trust for the path forward. So for us, I think that was the most enlightening piece of all of this work, is like, even though we were sort of tackling different areas, we were all sort of, rowing in the same direction, or we're like dealing with the same issue. But Crystal, I'd be really curious to hear your perspective.
Yes, same as well. We found that it was through those learning and those listening sessions that we really found out what the patients or those with sickle cell really needed. And it wasn't more so what leadership thought, it was hearing from them. And it's crazy because the exact same thing was mentioned time and time again. And a lot of it had to do with communication, not knowing, just not having a conversation. They felt that they weren't heard, that they would give the same concerns over and over again, but no one actually addressed the concerns. And even if they couldn't be fixed, can we at least know what's going on? So there were many of them who just said, just hearing from someone in leadership, just acknowledge that we're here. And we found for many of those with sickle cell, they spoke of, this is a disease, something they've had their entire lives. So they go from being treated as children when they're in sickle cell crisis. Oh, everyone wants to make sure children don't have pain. So they're medicated on time, no issues, but now they become adults. So now after the age of 18, they show up to the hospital in the same sickle cell crisis. And now it's, well, we're not quite sure you're in that much pain. Is this a matter of drug seeking? What's going on here? And just the trust that was eroded, because here are some patients who dealt with these providers their entire lives. So now here they come to an age where all of a sudden their judgment is questioned. So it really eroded health. So it really took a lot, trust to really build that back. But I'm glad that leadership understood it was necessary to do so.
Yeah. And it sounds like what you created was a really valuable feedback loop and mechanism to listen and understand that maybe wasn't there before. And it is interesting to hear you both say, within this learning system, the challenges were common, that this was not unique, that other people had the same kind of early struggles or common roadblocks along the journey. And sometimes what we find is the challenges can be common, but the solutions can sometimes be one size fits one. And there's a lot of trying to test changes from this, change package or theory of change, as Leslie was sharing earlier, but then make it fit your setting. So can you give us an example of some of the things you tested and what you learned? If you got any results, great, but sometimes, the challenges are just as helpful in the learning. So I'll start with you, Surabhi.
Yeah, I think, Crystal, what you just said, like really struck, like it's almost like rung a bell in my mind, because I was like, yeah, that's exactly how we felt, is that just having leadership acknowledge that you're struggling, and the fact that say like, I see you, I hear you, and then I'm going to do something about it, is an incredibly important part of like what we discovered in our work. And I was extremely proud of our leadership for, frankly, and I'll use the word humility here, that they exhibited when they said, we are going to actively apologize. We are going to say, and so to give folks, like take a step back to give you a little bit of context of what was happening at Oak Street, we serve vulnerable, marginalized communities. We go in communities where no one else will go, right? Like we typically are the only care provider from a primary care access perspective in you know, a 5-10 mile radius. And that 5-10 miles is incredibly important, as we all know. And so, and the 3 clinics that we decided to focus our energies on are in the Dallas-Fort Worth area, where there is a lot of not as robust of a social safety net, but then just a lot of, you know, social disadvantage and community level vulnerability. And what we also, you know, we tend to hire folks from the communities that we serve, which is an incredibly powerful aspect of what Oak Street does. Is like, we never want to go in and say, oh, we know how to fix your problems. Like, we want to bring people that understand, that have walked your shoes likely, that can support you in your care. And so that's part of our model. And so many of our providers that are in those 3 Dallas clinics where we studied this are BIPOC that typically have come from the communities, either have been educated, are currently living in, or, you know, are now practicing and therefore raising their families, or, you know, they're building their lives in those communities. And so what we found in that is that there was I think the validation of needing to, like, we see you, we hear you, we're going to do something about it, was incredibly important. But the second piece of also was acknowledging the amount of vicarious trauma that our providers and care teams were dealing with when it came to the care that we provide. We as an organization go above and beyond in terms of what we do for our population, from providing them transportation services, to addressing their social needs, to their behavioral health needs, to the point that many of our providers, if their patient's not coming to see them in clinic, will go and do a home visit. Even though that's not a standard part of the care that we provide, they will do that because that's how much they care about their patients. But as you can imagine, right, that all takes a toll on our providers. And so acknowledging those pieces, and frankly for our leadership to recognize that that was a big component of what was happening locally that was causing breakages and mistrust, because we were asking our providers to do a lot of things, but at the same time not really acknowledging what they were already carrying with them, you know. And so I think that was a big piece. And when our leadership sort of uncovered that in partnership with our team, that was the first thing they said. It's like, they used the words, "We are sorry." You know, we apologize deeply for not recognizing this, but then, like, also not, you know, explicitly acknowledging it, and then supporting y'all in the process. So that was such a powerful moment. Like, there were tears shed in that moment, both on the leadership's part and our frontline team staff. And I think that really created a platform for us to move forward a lot more sustainably. And what I'll just end by sharing, and then I'll throw it over to Crystal, is since what we've discovered from this project, we've developed sort of a robust, like, peer network support for our care teams to support each other and debrief on some of the tough cases that they're seeing. But then also we are really trying to pilot some more actual, like, structural changes to our care model, so that it allows more decompression time between patients, that allows our teams to really take that breath and, like, really say, whew, that was a lot, you know, and then really, like, could, you know, sort of reconvene and then move on to the next patient, because even that helps them a lot. And that's what we heard from our front lines. And we're really now thinking through, how do we take what we learned from this project and create an organization-wide, like, preventative framework that, you know, sort of addresses this early on. We never want to let it get to this point. And I hate to say that, but, you know, we never want to get to that point where we're doing kind of a retroactive fix. We want to be as proactive as possible, and staying true to our mission of, like, rebuilding healthcare as it should be.
I will say it was very similar for us on our end. In One Brooklyn Health, we actually had the chief executive officer during one of the town hall meetings actually apologize and acknowledge the mistrust and the lack of trust that the community the patients had with the system itself. It was something they weren't expecting, but it went a long way and was extremely impactful. I will say that I think it also helped the frontline staff as well, because what we didn't realize at the time, it wasn't until we started the pilot itself, that many of the providers in the ED and urgent care, where they would treat these people with sickle cell when they came in, they weren't sure. They themselves did not feel safe with the healthcare system. They figured, now, if I go ahead and I medicate this patient based on their pain, is the hospital going to back me up? Are they going to say that I'm on my own by over medicating this patient? Even though the patient's saying this isn't enough, the providers themselves did not feel that they had the backing of the healthcare system. So that actually had to be built as well. So in doing so, this protocol that sat on a shelf that hadn't been implemented because no one felt they would be supported in doing so, we were actually able to get a protocol rolling and signed by senior leadership and is now in place so that those with sickle cell, when they come into the ED, when they come to urgent care, here is this guideline that they can use. Both the healthcare workers, the providers will know they're protected and they're covered, and those seeking care know that they're covered and protected as well.
Wow. Yeah. And you both, just such incredible learning. And as Daniel said, wonderful acts of showing you care in your work and the spirit of co-creation and respect for the people you're working with in this work. But you touched on something we mentioned in the onset, which is this macro point of learning around the importance, but also the challenge in this step around acknowledgement. So I'm wondering for a moment, if I could come back to you, Leslie, and ask you, can you share more about this and some of the learning?
Yeah, so I'll reflect on a bit. I mean, first of all, I want to say congratulations and thank you for sharing. And there has been, a lot of conversation about apology, and quite frankly, a lot of fear about apologizing. And apologizing is just that first step in acknowledgement, right? We have to have energy left. We have to acknowledge and then redress and then build systems that are about being trustworthy, right? So we need to make sure that we move through these stages as we're working with our workforce and with the community. But there's a real fear around apologizing, and every system is designed to deliver exactly the results that it delivers. Like, there's a reason why people are afraid to apologize in healthcare. So no one's crazy for thinking that way, that it's rational, and it is courageous to apologize. And we're now creating systems where people understand that's a safe thing to do in health and healthcare, but it hasn't been. But I also just want to point out that we under acknowledge, and I would love for Crystal and Robbie to reflect on the reality of this. But the theory that we worked on in the learning community with all the health systems is that the first step under acknowledge is to ask and listen and learn from the workforce and the community about what the historical breaches of trust are. Not make assumptions, not make blanket apologies for something that, if you've not gone through that first step of understanding what it is you're apologizing for. The second step is really confirming back that you're hearing it right? It's a bit of a teach back, if you will, to, yes, we heard that this is the harms that were created. And then the third step is recognizing, acknowledging, and sometimes apologizing for past harms that have broken trust, even if it wasn't on my watch, even if it didn't happen in my leadership. My organization did this, and you can apologize for what your organization has done. But I just wanted to mention these steps of asking and learning, doing a teach back to make sure we heard it correctly, and then considering acknowledgement and apology. So I'm wondering how that lines up for you. Is it just, I don't know if that answers your question, if that's, but I was sort of curious how
Yeah,
they was
no, I think so. And I think it's helpful that you said it doesn't always mean apology.
That's right.
Sometimes it does. And I'm wondering, would that have landed if there wasn't an apology? And so Crystal and Surabhi, I'll leave it to you if one of you want to chime in on that.
Honestly, I think that the One Brooklyn Health System, like they were created 2016, but that, myself growing up, that was my neighborhood hospital. So I knew the reputation the hospital had, and it wasn't a good one. And it wasn't just one that I thought, it's just the community as a whole. So there was so much that happened rightfully before One Brooklyn Health was even created. They were formed in 2016, but this goes back so many years, decades. But they acknowledged that. They acknowledged the fact that there were things that were done that weren't right. There were times when patients were discriminated against, and they really did apologize, and not just apologize for it and acknowledge it. they said, you know what, we want to hear what it is you have to say. This is, mind you, this is after the listening sessions. This is when the acknowledgement and the apology came. But even with that, they said, we want to continue to hear from you. Please don't think that this is just a one-off. We want this to be a relationship. We want to continue to hear so that we can continue to build trust. So I thought that was extremely important.
Yeah, and I completely echo Crystal's sentiment here that, yeah, similar to the work at Rise Up, similarly at Oak Street, we really spent a lot of time just sort of having these very open town halls where we were like, we're just here to listen. We don't have any questions. We just want you to tell us what your experience has been. Like, we want to hear, like, what is it that's like, that thorn in your side, so to speak? What are the things that are causing you to not trust? Or what are the things that are impacting your burnout rates or your trust with the organization? And the level of vulnerability that our teams led with is something I really have to commend, because it does take a lot to really open yourself up and say, I don't know if anybody's going to hear me. I don't know if anything's going to be done about it, but I'm going to use my voice to advocate for something that I know is right. And our teams were just so open and honest in their feedback that we were able to use that and then, obviously share that. And we, by the way, did these listening sessions without the leaders in the room, because we wanted to create that psychological safety initially to make sure that, we were getting the information. And then we were obviously respectful and checking with the frontline staff to say, hey, is it okay now if we invite the leaders into the next session? Or is there a better forum on how we can share, your feedback? And so, yeah, after much of that is where, once we shared that information with the leadership, and they heard verbatim from the frontline staff what their experiences have been. One quote that I'll share is like, hey, we're drowning, like throw us a life vest. In the level of burnout that they were feeling, again, the level of vicarious trauma that our team members were feeling. And when our senior medical director and our vice president heard that, I mean, there were tears in their eyes. They were like, wow, we had no idea that this was happening. And I think to Crystal's point, we've really used that as sort of as a method to now like develop robust like feedback mechanisms, and how empowered I think the teams now also feel to take those concerns directly to the leadership to say, hey, this is not working for me. Like, what can we do to create a solution together? So that not only does that help my levels of burnout, but then the rest of my teammates as well, and their staff, so their medical assistants, their scribes, their social worker, et cetera. So I would definitely say that acknowledgement is important, because it's sort of almost signals that like you're taking ownership, and then you're essentially agreeing that you're going to do something about it. So I think that really, I think, was that like sort of step one of what came of the many steps we took after that, to set that ground level of like that sort of, hey, maybe the door's not open, but we have a window right now, and we're going to keep building on that.
That's great. And I'm finding that there are some really great questions coming in the chat. And so I'm going to try to limit myself right now to one more question for each of you before we turn to some of the folks on the line right now. So I'll start with you, Crystal. What is one thing, or what surprised you most during the work that you led? And I also want to ask you what you're most proud of. So it's a two-part question. Yeah.
Sure. I think what surprised me most was the unconscious bias from the healthcare team when it came to offering care to those with sickle cell. Like I mentioned, going from people who needed management of pain to people who are drug seeking. So that was something that was really eye-opening to see. I'm just thankful that, we're in the process of moving to the other side of that now, especially with the implementation of the protocol and things that are currently in place. What I will say, one thing that I'm most proud of is those same people with sickle cell now feel they have a voice. So they have been very vocal since, even being in the driver's seat of their own care. So much so that one of the people with sickle cell has actually started a nonprofit to be able to help others and educate others and family members know how and why it's so important to be on top of this. So I think a lot of great has come from it. And this is just an example of what can happen when they feel they have the backing of the healthcare system that they receive care at.
That's so beautiful. And yes, something absolutely to be proud of. Congratulations for that. And Surabhi, I also want to give you a chance to boast on some of the things you're proud of, but I also am wondering if you could share some words of wisdom for people to know about this work as they embark on it themselves.
Yeah, absolutely. I would say that, exactly what Crystal said, like empowering folks to have a voice is huge because it's sort of like that, you could give people you could be that voice for people, which is, I think, fantastic. But if you can really empower them to say, hey, actually, I can do this on my own now with the tools you've given me, is incredibly important. So I completely echo Crystal's sentiment there. And I think that the vulnerability that our teams led with and then sustained over time and frankly held us accountable. I won't lie to y'all, when I didn't share updates in a timely manner, people were not afraid to reach out and be like, Surabhi, it's been a couple months, since we heard from you, what's going on? And I appreciated that because they trusted me to know that I was doing something about it, but they also felt comfortable reaching out to me and to their leaders to say, hey, we want to know where's the progress, are you actually delivering on what you said you would deliver? So I'm really proud of that. Like the fact that our teams now feel comfortable to say, we got this, is huge. And in terms of words of wisdom, I would really say, I think I would be lying if I said like the task of understanding and evaluating the status of trust and trustworthiness is daunting, right? And I will say this, like in the beginning, we certainly felt daunted, but I think what it ended up allowing us to do is having deep sort of organizational introspection, lots of uncomfortable conversations, but then the courage to take the ownership where there is work to be done. So that's what I would say. Like, I think that, yes, it can seem scary, but it's doable. And so the ability to like say, okay, we are going to do this. We are going to meet people where they are. We are going to understand, what their needs are and then support them is really important. And then like, I would say the other words of wisdom I would say is like, get your leadership support, because just like Crystal said, making sure that they're on board, both from like our central leadership, but then also our local leaders was a really vital component to proceed with confidence. So like knowing that whatever we unearth, that we had the backing of the organization, both centrally and locally, to evaluate and address, and that they would welcome the feedback that was being shared with candor is really important. And then, yeah, like I really do think like the level of openness by the frontline staff, the transparency with, how we were going to do things, holding us accountable. Those are all really incredible things that, I fondly look back on. And these are relationships that I've maintained where one of the providers just messaged me today and shared she's very excited to see that now there's a more health disparity lens being taken into mammogram screenings, and she's using that to really advocate for some of the local initiatives that she's doing in her population. So just seeing that level of empowerment, like that makes my day.
Congratulations. That's so exciting to hear about. And yes, absolutely lots to be proud of there. And, Leslie, we're in the process right now, the foundation and IHI, of looking at what could the next phase of this work look like together, because we're not done in supporting this great work. And at the same time, as you, Crystal and Surabhi were talking, I was thinking, leadership support, that's got to be a critical input for not just getting it started, but also sustaining the work. I was starting to hear some themes around, the co-creation, these things that are kind of necessary in order to drive this work. But Leslie, I'm curious if you've reflected at all about the sustainability of this work or what it could look like for some of these pilot sites. What have you learned there around sustaining the momentum that they've started?
Well, I think, the principles that are used and the steps, the parts of acknowledging where you're going out and listening and learning and doing teach backs and owning changes is a cultural shift. And I think that's what Surabhi is talking about, and that's now being picked up in other parts of the organization, for example, around mammograms, and what Crystal was talking about in patients having a voice, right? So it really is a shift in culture through behavior, right? We're just to make that very concrete. I mean, I think in terms of this work, overall, we need deeper learning, and ABIM Foundation is investing in deeper learning. There's a great question in the chat about, well, what's the real driver of, what's the harm basically that we can prevent around breaking trust. So, continued deeper learning, I think, is really, really important. I also think, I would love to get this acknowledge, redress, build, like, what does that really look like, into as many hands as we possibly can, to let people say, where are we doing a good job as an organization around, acknowledge, redress, and build? Where are we doing a good job around trustworthiness? Where do we need to get better around trustworthiness? And how can we be part of a learning community so that we can accelerate our own work of being more trustworthy? So I think, getting this out into the hands of all of you on this webinar, so that you can start to test and understand where you are as an organization and continue to build your trustworthiness is incredibly important. And I think, one of the takeaways is that this is teachable, learnable behavior change that we're talking about. There are like concrete steps that Surabhi and Crystal have shared with you that people can take to improve trustworthiness. So each of us showing up as learners and as teachers, around not making this vague in any way, but being very specific about what this actually looks like. Because there's one piece if I can just add, that I haven't had a chance to mention, that I think is really important. And I was looking at our health system partners to tell me if this is not your takeaway. But for many of the systems, what we learned, and actually, Crystal, you've talked about this personally, our workforce is also our patient population. And our workforce and our patients, here's a shocker for us, talk to each other. And when our workforce is not feeling like we're working in a trustworthy organization, guess what? That impacts how we show up in the provision of care and in our care teams and in our interactions with patients. So by working on trustworthiness in our workforce and or our community, we're actually impacting both. So I just say that to, when we think about the sustainability or the why this is important to sustain, that's one of the reasons, because it has a very, very broad and wide impact.
And I think you just answered, Leslie, a question that came up in the chat a while ago from Leslie Grubbs King, who was saying, when you say community, who are you talking about?
Well, I will say that we centered this work and the development of this theory of change that we then tested with Crystal and Surabhi and other health systems was centered on the experience of the BIPOC community, because as I said, we centered it on understanding mistrust. And guess where mistrust has been the greatest, right? People who have been marginalized by our health systems. So when we say community, we do largely mean BIPOC community, patient community in that reference.
Crystal and Surabhi, anything you want to add to that?
Yes, if I may. Also, just to touch on Leslie's point, I was so glad I had the opportunity to also be a part of another part of the community when it came to the housing developments. And I will say, I just took the time. If you just go in and you listen, they're willing to share. They just want to know that someone wants to listen. So just being there, sitting in the tenant association meetings, listening to the concerns, bringing that back to One Brooklyn Health. Like, this is what they're saying in the community. This is how they feel about the healthcare system. These are the issues they're facing. I kind of saw it as an advantage for us. So in doing so, when the time came for me to reintroduce them to that healthcare system, I had already built a relationship with them. Myself and others who work here had already built a relationship with them that they trusted our word. And it was easier for them to go then and seek care. So just don't be afraid to get in the community. If you're doing it and it's coming from a sincere place, they'll understand and they'll realize that. And it just benefits everyone in the long run.
Thank you for that. And you also have a question, Surabhi, before you chime in, from Tara, who's asking if you can share the name of the nonprofit that the patient you worked with created.
Sure, no problem. And honestly, when I was looking down and looking away, that's what I was doing. I was getting the information.
Oh, you're awesome. Thank you.
Double duty, no problem. So it's Sickle Cell Empowerment Initiative, Inc.
Great. Thank you so much for that. And Surabhi.
Sure.
Yeah,
Anything, sorry.
I completely, like, Crystal, it's so interesting how like what you're saying is like so spot on with like what our experience was. Is like, don't be afraid to just like dive in and just like lead with vulnerability of just like, I'm here to understand, like with that approach. And you know what our team I think just did is like, we're not some like team that's descended from the headquarters that are just going to come and have this little town hall and then just disappear and you're never going to hear from us again. Like that relationship building, Crystal, that you highlighted is spot on. I mean, and to the point that, you know, now we're way past a year from this project since it first started, and we still have these ongoing relationships. Few of the providers that we partnered with are now part of our Health Equity Advisory Council. So there's a lot of just like cross-pollination that's occurred. And that empowerment piece has been so huge because like I see their voices now popping up everywhere. And that to me is like, what a cool thing to experience and see. But I think, Crystal, to your point, right? Like we just have to give people that platform. We have to give them the opportunity to share their concerns and then build that trust and relationship with them that like you're going to do something with it. I think that was like, I keep reverting back to that because that was such a key element of what we did is like, you know, even when there were no updates, we were saying, hey, just so you know, we're working on these things. So like even that meant a lot because it was like we were constantly closing that loop.
Yeah. Yeah. And Leslie, we would often at IHI use Kanbans or visual management boards to say, this is what you said, this is what we're doing. And there's stuff visibly up there that maybe it's not being actively worked on, but it's visibly showing that it's been heard somewhere important. There was a pre-question I wanted to ask you, Surabhi, that came in. Do you think it's different establishing trust with a population of elders like at Oak Street versus younger adults?
That's a fantastic question. Wow. That's whoever asked that. That's a great question. That's interesting. And I Leslie, I would actually defer to you as like the true subject matter expert here, but I would say yes. I mean, my gut instinct is to say yes, but then also no, because I think trust is trust, right? I think to me, it's just like, are you really like meeting the person, regardless of whether they're an elder person or a younger person, are you meeting them where they are? And like then really creating sort of a customized approach to whatever their needs are. So to me, that's how I would answer it. But Leslie, Crystal, I would defer to you to jump in here.
So do you want me to say, go? Okay, I'll go. You're right, unmute. Okay, I'll take that signal. I would say exactly what you said. I mean, I was like racking my brain. I'm thinking like through the research and I'm thinking, wait, what's the research? I'm thinking, no. Right? With every team that we're working with every person that we're working with, it's the stopping and listening to where the trust has been broken, doing the teach back of what we heard and acknowledging and apologizing for that, and then redress, figuring out what the systems we need to build, how we need to redress that, address what happened, and then the systems we need to build that make it happen again. I think it might almost be, I'm going on a limb here, it might almost be a mistake to try to look at it and make assumptions by age. We make a lot of assumptions, for example, about older adults and technology, that if we want to listen to an older adult, then it only needs to be in person and then they're not going to be able to use technology. But actually, that's a false assumption. There's a lot of older adults who very much want to communicate using technology. So I wouldn't want to make any assumptions, even in the way that we ask about and learn about where trust has been broken, and get ideas for how to rebuild trust. So I think you're just right. I think we can't make those generalizations. And I want to say too, by race and ethnicity as well, sexual orientation, and gender identity. I think it was important to understand. I think it's important for us to measure, again, trust as an outcome and make sure that we are improving trust across all the different characteristics of our communities and our populations. And I think the only way to do that is to not make assumptions about the different populations. But it is important when we're looking at improving and we're testing interventions to say, did this help rebuild trust? That we do make sure that we look at that data stratified, so that we are doing no harm and improving trust across populations.